especially Dr. Parimal Swami and Dr. Abhishek Srivastava for inviting me and giving the opportunity to discuss how to choose rationally between the biologics and biosimilars when it comes to the basal insulin therapy. As we know that we have the original innovator biological molecule and then we have the biosimilar. So like differentiate how to make the informed choices and to differentiate between, in fact, like we all have done in our school days or this when we were kids, that तीन अंतर ढूंढो, दो अंतर ढूंढो, and जब आपको अंतर ढूंढने हो तो आपको बहुत डीपली देखना पड़ता है जब अंतर ढूंढने हो कि कहाँ अंतर है. अदरवाइज मेरे ख्याल से इस स्लाइड में कहीं दिख रहा होगा आपको, अदरवाइज विल सी कि कितना डीपली देखना है अंतर ढूंढने के लिए. So when it comes to the biologics, in next 8-10 minutes I'll be discussing how to differentiate between biologics and biosimilars. So like when we talk of biologics, these are generally large complex molecules which are manufactured by the recombinant DNA technology in any molecule or any microorganism or a plant cell or an animal cell, and they are made from the recombinant DNA technology with the help of the monoclonal antibodies. Whereas when it comes to the biosimilars, they have a highly similar, has no clinically meaningful difference from existing approved reference product. But when you see very closely, if you see in the biosimilar, small differences are allowed in the biosimilars as compared to the biologics. So they are almost practically similar, but you have to see very deeply, go inside to find out those two differences or one differences between biologics and biosimilars. So, but there we should understand that these are not just the generics, because like we see that when the molecule gets off patent, we have the generics of all the molecules, but the biosimilars are not the generics, they are biosimilars, not the generic version of the original innovative molecule, because biosimilar manufacturer does not have access to the original molecule clone. So they are similar, but not the generic version of that original molecule. When it comes to the differences between this, like what is required for the biological to develop to demonstrate the safety and efficacy in patients, conventional clinical trials to demonstrate efficacy, safety in all claimed therapeutic indications, and mainly to compare, like they have been studied in all phase 1 to phase 4 clinical trials to differentiate between, to compare with the placebo or the standard of care, and then ultimately they are being studied for the positive benefit risk, mainly established based on safety, efficacy trials or all. But when it comes to the biosimilars, they demonstrate biosimilarity through comparative efficacy, safety with innovator, not with the placebo or the standard of care. And the comparative clinical trials to exclude clinically meaningful differences, they mainly show clinical evidence with the reference medicine using sensitive endpoints in a population and demonstrating biosimilarity. So biologics are vulnerable because like they have been manufactured with the stringent criteria, they are vulnerable at every stage of the development process and ensuring the product is safe, stable throughout production and continuous. So like when it comes to the biologics, process is the product, because there are more than 250 tests involved in the process of manufacturing a biological product, and any small change in the manufacturing condition can result in subtle changes in the final biological product. So we need to understand that. So there may be a manufacturing consistency, like if there is a manufacturing inconsistency, then there might be the efficacy might be different, and there may be product specific factors which has to be kept in mind. So when it comes to the interchangeability of biosimilars versus biologicals, when like we define interchangeability for products administered to a patient more than once, that the risk in terms of safety and reduced efficacy of switching back and forth between an interchangeable product and a reference product has been evaluated, and products with the same clinical results as the reference product in any given patient. So interchangeability means the substitution without the intervention of the prescriber. So we know that the biologics are the complex molecules. The biosimilars markets authorization must be based on a comprehensive set of the comparative, analytic, non-clinical and clinical evidences. Once biosimilars are on the market, they're being studied from the the feedback from the the data or the biopharmacovigilance studies, and then they keep on adding the information about the biologic products. And if we talk of these biosimilars, like they have been not addressed with the Indian regulations, like CDSCO, like the guidelines were they were not being studied in that in the as per the CDSCO. And if we talk of the original innovative molecule, that is glargine, which we are using for almost more than 2 decades, we have seen this data so many times. This is the data from the original trial, which has shown that they are being efficacious as versus the standard of care. And this study was done in almost more than 12,000 patients, and it was found that the CV safety and efficacy of the original molecule is there is no adverse CV outcomes with the insulin glargine. And if we talk of the cardiovascular outcomes, the core primary outcomes were the non-fatal MI, non-fatal stroke or death. We have seen that these events plus the revascularization, hospitalization for heart failure, the rates of the incidence of cardiovascular outcomes were similar in the insulin glargine versus the standard care. So they are not increasing any cardiovascular concern. And I'm sure we all see such type of patient day in day out in our OPD, where the patient those who are coming with oral anti-diabetic they are not controlled with the oral antidiabetics, 2 or 3 oral antidiabetic, and definitely patient needs an insulin therapy. And I'm sure we all agree that to start with the first insulin therapy is preferably a basal insulin therapy along with the oral antidiabetic. And just for the postgraduate students, how what are the different recommendations, be it ADA, be it our own RSDA recommendation that if the A1C is less than 8, we can choose a dose of 0.1 to 0.2 units per kg to begin with, and if A1C is more than 8, we can choose 0.2 to 0.3 depending on what is the patient's profile, what is the patient glycemic status, what is the patient weight and the A1C. And definitely patient's education level and understanding the insulin therapy to up titrate and down titrate the dose, because that is more important when we are initiating a patient with insulin therapy. Because many of times what we have seen that we started a patient on 10 and he is continuing for the 2 months on 10 units and then come back, doctor insulin bhi laga diya par sugar to abhi bhi control nahi hui, because he is not well aware about the up titration and down titration. Because like we always fear about the hypoglycemia, so patient should be well educated about the up titration and down titration. And definitely if we see the efficacy of the insulin glargine, and we are using them almost more than 2 decades. I'm sure you are all using for more than 2 decades, and this has been started in different clinical trials where the efficacy and the true basal insulin as compared to like NPH and other, glargine has always been served as a true basal insulin without any peaks and troughs and a consistent insulin levels in the body. And so the glargine 100 was the first basal analog to be approved in 2000, and this has been multiple systemic evaluation of the glargine 100 across different studies, and this is the evidence is from the 54 study. This suggests that glargine 100 is an effective option for both insulin initiation and intensification used in the management of type 2 diabetes. This is the data from the Live India where the effectiveness of glargine 100 in a post-hoc analysis of the FINE Asia Gold registry was done, and almost 1,000 of patients where the mean age was 54.7 and the baseline A1C was 9.4. And if you see the average reduction in the A1C in 3 months it was 1.3, in 6 months it was 2.1. And the best part is that almost around 1/3 of the patients they achieved a target A1C of less than 7. Whereas almost 2/3 of patients, like 61.7% patients, achieve the A1C of less than 7.5. That is the ultimate aim or ultimate goal when we are treating a patient of type 2 diabetes. And when we start a patient with the insulin therapy, we have 2 phases in mind. That is, one is a weight gain, another is hypoglycemia. So if you see the basal insulin, there is not much weight gain. We know that they are not causing much weight gain. In fact, this is just because of the correction of the glycemia that leads to the weight gain. And so the weight gain is not a major concern, as well as the hypoglycemia. When the basal insulin is being compared with the premixed human insulins, 25% greater A1C reduction is seen with the basal insulin as compared to the premix. And definitely there is an increase in the compliance or the convenience of the patient taking only 1 prick in a day and 2 basal insulin working for 24 hours. And as compared to the degradative part, yes, the comparable A1C reduction, so we can think of switching a patient to the comparable the basal insulin. And if we talk of the risk of hypoglycemia, I am sure we all agree that if there would have been no risk of hypoglycemia, no patient on this earth would have been uncontrolled. But only the fear of hypoglycemia which restricts us in going aggressively. We always fear the risk of hypoglycemia, so we restrict sometimes ourselves in going for the aggressive management. That is a major challenge. But when we combine with the basal insulin, like as compared to the other insulin or the premix, the risk of hypoglycemia is less as compared to the premix or the bias 30. So glargine 100, it has exhibited the better treatment satisfaction than the premix insulin. And if you see the quality of scores, like the treatment satisfaction scores as compared to the premix was better in the basal insulin, definitely with the one-sided therapy, and also as compared to the Evonolog premix plus ADs. So if we are thinking of switching a patient with the basal insulin therapy, definitely we know that with any oral antidiabetics we can combine their western resistant reaction maybe with the older molecules like the bigonides or the SUs. We can combine with the basal insulin therapy or even with the SGLT inhibitors and DPP4 inhibitors. So like basal insulin therapy can be combined with any spectrum, any patient of type 2 diabetes with any class of oral antidiabetic to achieve a target A1C. So there is a synergy between the basal insulin along with the oral antidiabetics to achieve the control. But the most important part while starting an insulin therapy or when we are starting a basal insulin therapy, definitely it is the follow-up and the patient education. About down titrate or up titrate. So we should have a clear-cut discussion with the patient when we are initiating a patient with the basal insulin therapy, that what is to be done in next 24, 72 hours, 1 week, 2 weeks. So in 24 to 72 hours when initiating insulin or titration, support insulin initiation and reinforce titration. In 1 to 2 weeks when patient report that the blood glucose reading, ensure titration is done occurring normally. And in 1 month when patient report blood glucose reading, ensure titration occurring normally, encourage patient with bi-weekly contacts. Thereafter, in 3 months, we should go for A1C. If not at goal, may continue the titration for another 3 months and follow up in a person or by virtual consult. Yeah, 6 months, if the A1C is above target, review the glycemic profile, review the patient